trainees, and I know there's a mixture of people in the group, is who is a child by definition in England? And I'm not sure if you're happy to kind of put an age is what we're looking for in the chat. Give a couple of minutes for people to commit themselves to that, if people are able to, or have a think if you're sharing a space with some people, what you feel that definition is.
So one comment in the chat is the age up to 18, or so under 18.
Excellent. Perfect. So first one in the chat's already on a roll and has that definition nailed down. So yeah, by definition in England, anyone who's not yet reached their 18th birthday. And I think what's important with that is thinking about it in the context of what we deliver in healthcare. So often our children's services go up to the age of 16, but up to the age of 18 is still considered a child. And then that brings us on to the next question, which is, what are we all talking about when we talk about adolescent health? And I guess I would ask you to do the same thing and pop into the chat. Where do you feel that age should sit? Are we talking about people up until they're 18, up until they're younger than that, older than that? And what is the lower limit as well? What age bracket are we looking at? And I'm going to see if there's anything coming into the chat about that, but I'm going to pop up some definitions that we have.
So one potential suggestion is 13 to 19.
Mm-hmm. So that would be more in keeping with the World Health Organization, who talk about adolescence as being up to a period of 10 to 19, so slightly younger than that, but covering puberty really, and then onwards and upwards to 19. Did we have any other advances in the chat?
There's just also a comment about being from puberty to about 19.
Yeah. So what we're thinking about as well is that the United Nations would define youth as from the ages of 15 to 24. So they sort of go from after puberty, although people can still be going through puberty up until usually the around ages of 18 or 19 would be the upper limits of starting puberty. But we in the UK have a definition of young people as being between the ages of 10 and 24, and that's as per our NHS England plan for the long-term plans, as well as sort of what is the general consensus from those with an interest in adolescent health. So 10 to 24 is quite a broad age bracket, but there are lots of stages, which we'll come to a little bit later, that we need to be aware of within that time frame. But I guess what I'm asking you to do is just kind of broaden your understanding of what we're discussing. So what are all the different phases that constitute the adolescence? Because maybe, probably not the people in this, but certainly when I do some teaching for medical students, some people in the auditorium are the same age as we're talking about in these things. And I guess one other bit that I'd like you to take away from today, because there's quite a few different learning points to meet your curriculum, but actually one of the things I'd like you to think about is the kind of portrayal and our stereotypes of young people that we have. So this is the sort of media portrayal from my youth right through to kind of more up-to-date examples of television shows where it's a bit grimy, a bit dirty, a little bit spotty, a little bit kind of interested in adolescence, but actually all of these young people, and I would do this as a quiz usually, but I think we should spend our time talking about some other things. But I just want you to look at this board. It's not to make us all feel inadequate about our achievements before the age of 24, but everyone on this board has done some pretty remarkable things within what we would still define as a period of adolescence. So they've been Nobel Prize winners, Olympians, Paralympians, professional athletes, humanitarianists across the UK and the US in terms of film and television. So lots of young people breaking boundaries. And I suppose I want you to take away from today is that whilst not everyone in your clinic will be achieving this level of stardom and fame, what they might have is a great potential to be judged slightly more favourably than some of the stereotypes we tend to. And just try and remember in your clinic that what we're looking at is everybody's potential and trying to improve that and thinking about that in a developmentally appropriate way, which we'll talk about a little bit later as well. So one bit that I talk about in my talks more so recently has been the concept of adultification. And some of you will be familiar with this term, and some of you, it may be a new term to you, and that's fine either way. But I think it's something we really need to be aware of when we're practicing medicine, and particularly around adolescence, because people mature at different stages and different rates. But this is a stereotyping that affects boys and girls from minority groups, and it's a sort of way in which we expect different behaviours from people of the same age due to their background. So we know that from the age of 5, black girls are viewed as more adult-like than their white peers, and this continues on into adolescence and beyond. And what can happen with that is that it normalises harm and changes the approach of professionals to how we interact with those young people, and can cause part of the problem for them. And one example was a really harrowing one from safeguarding, where a young girl in London, who was 12 or 13 at the time, had been strip searched under the Met Police when her teachers called them to the school, concerned about a smell of cannabis and possible drug use. But she wasn't given the opportunity to have a parent or guardian there. And the strip search was conducted within school property without anyone with parental responsibility being made aware. And I think it sort of highlights, whilst everybody involved in that case and since has been managed and has been told just how wrong that was to happen. And I think when you hear it starkly, it sounds obviously wrong to happen, but these things start to creep into practice, because people forget that we are looking and supporting children and young people. So if you want to know more, and I'm definitely not the person to speak on this topic sort of from a personal perspective, but I think it's an important part of our practice, the listenupresearch.org is a really good link to understand a bit more about this important definition around ages and stages. So one of the other bits to think about is that with adolescent, what is adolescent health and why should we be interested in it? And I suppose part of it is your medical knowledge and your understanding of puberty, what the physiological processes are. And I think most people get quite comfortable and familiar with that. So understanding your Tanner stages and being able to say at what stage of physiological development someone's at, and also brain development. But actually, there's a little bit around adolescent health that we need to start thinking about, particularly in the climate of mental health, which is an increasing area of our service, is this personal development. So this development of identity, the development of social and economic independence from others, and our relationships changing from being a familial relationship in which we are with our primary caregivers into a relationship where you're more concerned about your peers and the kind of acceptance into your peer group. And then that development of abstract reasoning, so being able to think of yourself outside of your environment and thinking about the perspective of others. And that changes during adolescent development, which is a huge change to be able to think about where you want to be in society and what you want to contribute. And then there's also kind of social change that happens throughout adolescence for young people that shapes them. And those are the world events. Obviously, many of the young people we're looking after at the moment have come through a pandemic, which was particularly affected them in terms of interactions with education and school and families and what that meant during that time, and ongoing changes around war and climate change and really worrying world events that young people have to navigate and understand whilst they develop their sense of self. And then they also have to develop their education and future employment and an idea of who they want to be in the future. So there's a lot happening during these years of development. And one of the most fascinating bits, and some of you who've maybe heard me talk about adolescent health before, I think this is an area that we really need to acknowledge more. I think we're very good with the under fives and knowing our developmental milestones when we come out of a pediatric training program, and being really clear that young people, when they're children and infants, meet developmental milestones. But what certainly during my training was less clear until I did it as a postgraduate was around adolescent brain development and the changes that are happening there. And really, it's the second biggest change that you go through. in terms of your brain development. So you continue to develop your brain cells into your 20s and 30s. For those of you in that age bracket, you'll be pleased to know. And then the prefrontal cortex structure is changing dramatically at that time. And just around puberty, when you go into puberty and through those periods, your grey matter really peaks and then sadly starts to decline. And you get this synaptic pruning, which happens. And what that allows is you to start to get more rational, more abstract thought, the ability to kind of think about items other than yourself in a slightly different way, and your social responses all change. So during your adolescent brain development, the limbic system, so the risk-taking feedback mechanism in your brain, is hugely sensitive. And there's been some really good research with Sarah Jane Blakemore and others looking at what happens during adolescence. But if you think about the fact that your risk-taking feedback mechanism is really hypersensitive, but your prefrontal cortex and your frontal lobes are actually continually going through a remodeling at that phase, which controls your reasoning and your thinking, then actually it's not a surprise that that risk-taking behavior can sometimes tip into being more of what you do than actually rationalization and being a very reasonable person and being able to see the impact of your behavior on others. So you can we're starting to talk more about early, mid and late adolescence for people that have got more interest in this as an area. And I think that's where the term 10 to 24 starts to make more sense, because you have this pubertal phase, pre-pubertal into pubertal phase, then you have a sort of mid-adolescence where all this brain development is continuing, and then a late adolescence when you can start to see that kind of adult perspective into things. So it's an interesting section, and I think if you want to hear more about it, this talk, which is from a while ago now, like 12 years ago now, is still one of the best talks on the adolescent brain that is available on the TED Talk, and I would recommend, if you've got 15-20 minutes, listen to Sarah Jane Blakemore. So why should you be interested? And I suppose my plea whenever I talk about adolescent health is to recognise just that this group of young people that we have in the UK makes up the same proportion of our population as older adults above the age of 65. And therefore, for obvious reasons, our healthcare systems think a lot about older members of our society because they have multiple morbidity and they have lots of different issues that need to be addressed, and that's reasonable. But we have a really big proportion of society who don't really always get thought about at all, and somehow have so many transitions, both in their education and in their healthcare system. And we can do a little bit to help with that from the point of view of health, and just be mindful about all the changes that people are going through in those periods. So that's my sort of call to arms and plea. But what the next section of time that we're going to spend together talking about is really thinking about what is adolescent health and some of the top takeaways for you in your learning. And I suppose I am really keen that we always hear from the voice of young people and co-create things and understand. And the global burden of disease data that comes out is really, really helpful in understanding what matters to individuals. And according to young people, the top causes of morbidity as of 2022 were headaches, depressive disorder, and low back pain, which, if you're going to think about what do I need to be prepared for, if I'm going to do clinics with young people, you probably need to be prepared for those three topics to come up in a lot of your consultations. And I'm not sure that musculoskeletal pain is always something we feel particularly comfortable managing. So it's worth being really hot on your headache management, and then thinking more widely about mental health, but particularly depressive disorders, and then lower back pain. And then the rising issues of daily morbidity, so things that make a difference to people in their daily lives, according to young people as well. Acne tops the bill, which is something that we probably don't deal with very often, or as often as we should in consultations about other things. But thinking about the impact of that and whether we have an opportunity within the health interaction that we have with young people to think with them about their skincare and other aspects of their life that might be causing them distress. Mental health, as I said, is an increasingly common presentation. So 75% of mental health presentations that persist into adulthood present in adolescence. So you will be identifying and looking out for these kind of conditions in your consultations. And 25% of young people, this is a huge statistic, so 25% of young people go from CAMS into adult mental health services. So we have a large responsibility to be able to manage and support young people through transitioning to adult services with coexisting mental health conditions. And then what we're seeing increasingly are our NICU graduates, if you like, so neonatal complications and complex disability. So thinking slightly differently about our adolescent cohort with young people and being mindful of making sure that we support people who've got learning disabilities and making those diagnoses so that as adults they can access the correct services when there's not the same wraparound care as there is in young person's health or paediatrics, where we're quite good at looking at the whole picture. Or when we're transitioning care actually to someone who's in a general practice position, who's going to be managing people with really short appointment times and having to grapple with quite a lot of complex disability. So that's another area where if in the future, as you're building services or becoming part of them, you want to have a bit of a think about how you're catering for that group. And at the Royal College of Child Health most recent conference, which was on adolescent health, we heard from Russell Biner about the idea of these pandemics of youth. So obesity and mental health being the pandemics that we need to be preparing for and having a strategy within our daily practice for our appointments with young people, but also our kind of responsibility for a public health approach to this and contributing to those discussions. So if you take anything away from this talk, I think these are the topics to hone in on, because these are the ones that will come up day in, day out when you're doing an adolescent clinics or when you're in general practice doing clinics with young people. So those are key. So let's have a think about a case. We've got about half an hour or so. So we'll work through hopefully 2, maybe 3 cases and think about how they link to some of the concepts of adolescent health that you need to cover for your Progress Plus. So the first case is a 14-year-old female who's attended ED with an infective exacerbation of asthma. And what would you like to know? And you can pop in the chat, what are the questions that you might be asking in an emergency department if someone's come in with an exacerbation of asthma? And Martina, you might be able to shout out if there's anything.
So one of our questions is, what treatment are they on?
Yeah, so this patient was on a preventer inhaler. They were on beclomethasone, which they were collecting from the GP, and they used salbutamol as a reliever inhaler. They had a spacer device, but it was a yellow spacer.
One of the other, so 2 more questions with regards to sort of compliance with treatment and or phrasing that as how many days a week do you remember to take your inhaler?
Great, that's a really good question. So you're wanting really to check, are we giving the most effective medications for this young person? And then the second thing is, are the medications that we're giving being taken effectively, isn't it? So I think those are really reasonable questions to think about, particularly in this age group where we know that young people are taking more control of their healthcare. And so the kind of worry that we have about compliance comes in. So yeah, this young person actually was doing really well. So every prescription had been collected with the support of their parent. They actually had good inhaler technique and no concerns about use, but the concern was that they would carry a smaller spacer device than they should have been for their age. And then the team did a little bit more of a discussion with her, and she was being bullied on the estate by some local teenagers, which was partly why she didn't want to carry a different inhaler. She wanted something that could go in her pocket. And there was some anger management issues that came up. and she was actually estranged from her father, so she was living in a single parent family. Is there anything else that you would be thinking about at that point that's coming up in the chat?
Some comments that have come through are with regards to sort of potential triggers, so smoking, vaping, allergies, mold, or dust, as well as if there's any kind of peer pressure from friends with regards to things like smoking. In addition to that sort of wider perspective of how are things at home, where do you sleep?
Yeah, great, well done. So you guys are thinking really well about the kind of triggers for asthma, the usual history that we would take around the social history, but also delving a little bit deeper for this age group into what might be hindering or might be facilitating her to manage her condition. Because we know the risks of not managing asthma well can be really devastating. So actually it's a really important thing. So yeah, so thinking with this young person, we're going to come on to a bit more about how you might take that history. But she was optimized on her medications. She was already taking good levels. This was an infective exacerbation, so actually felt to be not an inappropriate attendance to ED, if you like. She had a spacer change, so we actually changed her to a different inhaler that didn't require a spacer, that was a easy breathe inhaler for her to use, which was easier to carry around. And then she was referred, very fortunately, in our department, we have the availability of youth workers from our ED, and they looked at some sessions focused on anger management and techniques for her self-esteem. And that included things like daily affirmations, journaling, meditation, and working with her once she left the hospital, which is an incredibly privileged position to be in, to be able to refer to a service like that. But I think shows the importance of having those kind of services available. And what I think this really highlighted was, with a simple history, you would have got a good understanding of this young person, but with a more targeted history, the team that we're on, which I don't take credit for, it was a different team that was working that evening, but I thought it was an interesting case, really used the heads assessment to understand a bit more of the pressures for this young person. So some of you in the chat mentioned there about bullying and kind of what were the peer pressures. So there was a lot of peer pressure for her to smoke and vape. And there was that bullying on the estate, so she didn't want to appear particularly different. So she would take her inhalers only when she was at home. She wouldn't take them out with her to be seen kind of walking about the estate. So she would wait until a bit late to give her reliever inhaler particularly. And there are different ways of doing these discussions. We talk a lot about heads in adolescence, which hopefully we'll come to in a minute and talk about in more detail, and many of you will be using in your daily practice. But there are other ways. Heads is just one way of structuring your discussion with a young person, but there's motivational interviewing, there's the me first model, and there's just general professional curiosity. So I think that's probably what most young people that I work with, that I get feedback on how things are going, appreciate. They want people to ask questions and to understand a little bit why you're asking the question, and for you to genuinely seem interested in the response. And we're not asking questions to be intrusive and nosy and for our own personal interest, but we're asking it under a sort of professional curiosity. And I think one young person that I work with said it best when she was like, I don't need friends. I don't need another friend. I need a health professional to be my health professional. And she was doing that in a kind of feedback in a workshop that we were doing. And I thought it was a really powerful way of legitimizing and explaining why you're asking these questions. So hopefully you all feel that you understand what heads assessment is. We'll come to that in a minute, but that you also, just a little reminder to mention confidentiality at the start of your discussions with young people. So you're inviting them in that space to have a discussion with you, but lots of young people don't necessarily have or have not had that many interactions with health professionals on their own. And so what you want to start to establish is empowering them, and even by having one conversation with one young person on their own. So I usually would do this with people where it's developmentally appropriate above the age of 13. If I'm seeing them in clinic or in A&E or on the ward, I offer them a confidential chat, which is a safe space to have a discussion with your health professional away from parents. And at the start of that, I'll always caveat it by explaining to them what confidentiality is. And often I'll do that by saying, what do you think confidentiality means, and you'll get lots of interesting answers and responses. But I would usually say confidentiality means that what you discuss between you and your healthcare professional, in this case myself or whoever else I have in the room with me, doesn't necessarily need to go further than this unless I'm worried about you or worried about someone else's safety. And I'll let you know if we need to tell someone to help us, help you, or if we need to tell someone else because I'm worried about someone's safety. But we'll work that out together. But what you can never offer is complete confidentiality. And I'm sure you all know that, but I just reiterate it because it's very easy to get into a position where you've started asking questions and the young person doesn't really know what the dynamic is. But if you're open about it, you give them the opportunity to decide if they want to tell you that piece of information or not. And I think that's quite an important difference. Because it's privileged information that you're getting from these young people, and it's for them to decide if they want to. And we also know that in those discussions, it can take several times of having a discussion that feels safe and supportive before people will disclose something of importance and relevance to them. So we know it takes up to 7 or 8 discussions for young people because we've asked adults who were in that position to disclose significant abuse or domestic violence. So it can take a number of times. So I'm not expecting everyone, every time you do a heads assessment, to gain a piece of information that needs action. But I suppose what you're doing is you're creating an environment where they get used to the idea that actually you get time with a health professional on your own, and maybe next time they feel more confident to disclose that. And that's the same as when you're in training and you take a medical history from someone and then the consultant comes around and takes the same medical history and gets a different piece of information. It's not a reflection on your history taking, it's just creating the space that allows people to share. So the HEADS assessment is an interview tool. It was developed in the 1990s, so a long time back now, and it has a yield of 1 in 3. So basically, for every 3 people you have a conversation with using the HEADS assessment, you'll get 1 person whom you have some information that you need to do something with. And I think that's always the nervous part of HEADS for people who are less familiar with doing it or feel less confident doing it. And just for context, the newborn examination that we do twice, so we do at birth, 3 days, first 3 days of birth, and then at 6 weeks, has a yield of 1 in 20. So we think that's a reasonable intervention to do twice in someone's healthcare journey as a neonate. But actually, the HEADS assessment has a much higher yield, and potentially the morbidity of the things that we're discussing can be equally as important. So it's built up as an acronym to build the rapport. So going from the things that are meant to be easier to talk about to the things that are trickier. The caveat on that is that it's easier for us as health professionals to talk about home education activities and drugs because we sort of feel like those are things we're entitled to ask about. But the S's feel a slightly bigger stretch, I suppose. So it's not necessarily easy for young people to talk about home. That might be the biggest challenge for them to talk to you about. So you may have to adapt your HEADS assessment if you're not getting somewhere or you think that you build rapport opportunistically talking about things that come up for the young person. And it needs to be developmentally appropriate. So obviously for someone who's, as I said, I usually speak to people who are 13 and above on their own, although 10 to 24 is the age range. So, but you have to be developmentally appropriate. So thinking about the questions and delving into them in more detail, but that doesn't mean being presumptive about what someone may or may not have engaged with. So I think particularly around sexual health questions, we tend to underestimate when people might want to start talking about those things with us as healthcare professionals. So it's worth thinking about it. We also know from lots of research that's been done into this area that young people with learning needs or young people with physical disabilities tend to get the sexual health questions missed out more frequently, even although they may well be sexually active in the same way that their peers are. So just be mindful that you're not bringing in any of your own prejudices or stereotypes into those discussions, and try and be mindful to be at least have a baseline heads assessment that you would do with everyone. But you want to be sensitive and culturally appropriate to people's responses. You know, people are giving you clear indications that they don't know what you're talking about, or that that area is not going to be of significance to them, but they need to tell you that. And one thing that I would say that's really helpful and gets updated quite regularly is the YIPSA gap, so the Young People's Health Specialist Interest Group. We'll talk about them at the end, but that's the group affiliated to the Royal College for people with an interest in adolescent health, and it's got an app that has example questions on how to ask heads assessments and sort of ideas around that, which can be really useful. So I've given you a clue on some of these, but if you can pop into the chat, what are all the letters? What do they all stand for in the heads? Throw out some, preferably towards the end, because I think I said home and education. So some of the other letters, what do they stand for? And hopefully Martina can read out to me what you're putting in the chat.
Yeah. So we have sort of drinking, drugs, sex, smoking, social media.
Perfect. Any others?
Sleep.
Sleep. Well done. Well done who put that one in. Often gets missed out. Yeah. And depending on where you discuss it, mental health might come under S. Some people put it there for suicidality and mood and self-esteem, and other people put it in the D for kind of drugs, alcohol, depression. So it depends where you put it in. But those are all the areas that we talk about. And the S's keep extending. Sleep, social media, you've mentioned them all there really. But we started with two S's, and it's elongated as we've gone on. So these are the acronyms that are most commonly used. And I think what I would encourage you to do is think about, does it make a difference? So we know that in our local A&E, this was done pre-pandemic, they looked at 60 children who attended the ED screening using heads. And of the notes audited, 62 before teaching and 60 after. So they took 60 children on average. Prior to any teaching or any discussions about heads in the department, there was 3% had an adequate social history taken, which is pretty damning actually. But we determined adequate social history by just having one thing mentioned for each of the heads acronyms. So at the point of time, it was only 2 S's. So we were expecting people to write down 6 things from the social history to determine it adequate. And then the team did a quality improvement project, and they looked at putting in a printed pro forma, and they got it up to about 1 in 5 adequacy. But following the pro forma and teaching, it went up a little bit more to just about 1 in 3, but still not great. And the interesting bit that they found, which I think makes complete sense, is that the best recorded things were always home and education. Almost everybody had that actually. But the worst recorded were as you went further into the heads. So people feeling less confident asking about things that they didn't understand either what to do with once they were described, or felt comfortable themselves asking young people. So I think it's worthwhile being aware of that. And I think I've thought a lot about this because we do quite a lot of quality improvement projects here at the Evelina, thinking about how do we speak to young people on their own, and it happens in lots of places. And there are lots of opportunities to talk to young people on their own. So they get admitted through ED, then they get onto the ward, then just before they're going home, and then there's an outpatient appointment. But what happens at each of those is that in A&E, it's a really busy department. You're dealing with, if we look at the asthma example that we had, you've got a young girl who's come in, she's needing acute asthma management, she can barely speak in sentences. You're not going to sit down and do a heads assessment at that point. So there's clinical need. And also you're often there with a worried member of family who it's quite challenging to maybe separate away from. Not always, but sometimes in that environment it can't work. Then you get weeked up to the ward, and then you're on a busy ward round. You've got a number of people on the team with you on a ward round. There's new acute admissions coming in, new teams, you're just building rapport for the first time again there. You're trying to find a space and availability to take that young person to have that discussion, and there's often someone again at the bedside, so you're having to create the environment for it to happen. And then you get to the point where you realise this young person's about to go home, we've got limited time to intervene, the family are coming to collect, there's other bits that need to be gone through about medications, and suddenly that opportunity is missed again. And then an outpatient, you've got the same but in a really condensed way, a limited appointment time, often young people and their parent being seen together. And how do you run a clinic schedule with enough time to get people to come into the room together, separate out, then have them come back together at the end to have a sort of feedback. So it does elongate your appointments, and you have to think about it in how it's delivered. So often it doesn't happen. What I would encourage you to do, and I'll share this link with Martina to you, is there's a really nice example of a heads assessment in action, which lasts about 14 minutes. And it talks you through and breaks it down. So the actual discussion is about 8 minutes, but it's a 14-minute discussion of how to do a heads assessment from an Australian healthcare provider. And you can have a listen to it and start it and think about what's gone well and what would you do differently. Because I think it's easy to sit and say, oh yeah, I would ask all those questions, but actually getting used to saying it out loud and asking about sexual activity without making it sound like a really artificial discussion, and also knowing how to opportunistically take a thread of a discussion. It is a different kind of skill set. So if you don't feel particularly confident with it, it's a good way to get your CPD up. And we've already mentioned the app. That's the QR code. You can download the YIPSIG app. So at that point, I'm just going to mention a concept which some people might be familiar with in the group. I was going to do a poll on this, but I sort of ran out of time of how many people have actually heard of contextual safeguarding. But I think this case illustrated it nicely as well, and it's a really important concept in adolescent health. And that's the idea that when safeguarding was set up, it was set up to think about the biggest risks to young people, which was from their primary caregivers or extended family. But what we're realizing is that for young people, as you naturally start to move away from the family home, have more influence from outside. So things like your education surroundings, your neighborhood, your environment, your peers, those influence you more. We have to think about you in the context of that. So if you have two young people who come into an A&E department seemingly unrelated to one another, but with similar injuries, we need to start thinking about where did these incidents happen and is there a connection? And similarly, when we're thinking about safeguarding, are there particular flurries of activity that happen within schools where there's a higher rate of self-harm presenting, for example, because of some sort of viral TikTok thing that's being shared at that particular school through the WhatsApp groups there or through the social media channels that the young people are using, which is probably not WhatsApp at that point in time. But, trying to keep up with what is the trends across your region and area. And there's a lot of work that goes into this at lots of different parts of London particularly, but across the UK, where we have to think about what information do we share outside of our own healthcare system. But contextual safeguarding is really thinking, what are the pushes and pulls for that young person? You talked about it at the beginning, the triggers and the barriers to them engaging with health or being kept safe. And how is the family and home influenced by that young person being in it? Because as you gain your strength as a young person, as you go through puberty, you may start to be the perpetrator of some of the unease and violence within that family home, sadly. And then thinking about sustainable safety is one of the key pillars of contextualized safeguarding, and thinking about what can we do for this young person now to safeguard them, but what are we actually going to need to do to make sure that their whole environment is sustainably safe? And then the adultification that we talked about links in with contextual safeguarding. So are they living in an environment where there's constant threats to them that are from a system level rather than an individual risk? So If you want to know more about that, the Contextual Safeguarding Network have got a toolkit and a short video that you can watch that explains it a little bit more. And I'd be very happy to talk about how we use that in practice in sort of safeguarding care, case reviews and case meetings. I can't do an adolescent talk without talking about obesity. There's a bit of a segue, but we're just thinking about the topics that I want you to leave today thinking about. And one is that we are just seeing rising levels of obesity diagnoses. Particularly, this is looking at the age group of 16 to 24, who are finishing primary or secondary diagnoses of obesity in their hospital admissions. So this isn't even national numbers. This is young people who have been admitted to hospital in that age bracket. And you can see it's pretty starkly rising, which we know. But what do you do in clinic if you see a young person? Because we know that people shy away from the topic of obesity, really. So I think the main thing is if you've taken a really good HEADS assessment, you might get an indication. The other way of doing a HEADS that I sometimes do when I'm thinking about lifestyle is that I take a sort of typical day. So particularly when I'm looking at young people that have got fatigue or headaches or issues with post-viral illnesses, or if I think lifestyle is impacting a lot, then I'll do more of my history taking will be done in a kind of what's your typical day. There might not be a typical day, but if we think about it together, and you'd get an idea of when they wake up, when they go to sleep, and take me through what a day looks like for you. What do you eat? What do you drink? And it actually will give you a little bit of an indication towards it. And some of the tips around obesity that I have is that I've picked up along the way is looking at daily activity. Obviously, it's a balance, and young people respond quite well to that as a discussion point. Fizzy drinks and fluids first. It was a really good bit of teaching that I got when I was at UCLH, and it was talking about the fact that these sort of hidden calories that happen, sort of energy drinks, colas, stuff that people are having sort of liters of in a day. If you start with those first, you often start to see some gains early on for young people, and you can lose weight a little bit more safely. But making sure that we do the assessment looking for chronic health issues that might be contributing. And also that young people can attend some weight loss services like Weight Watchers if they have an adult going with them. So they can be under the age of 16 or 18, depends on what the Weight Watchers is. Most of them are above the age of 18 to be enrolled yourself. But if you're under that age and you have a parent or a guardian who's willing to go with you, or ideally do it with you, which gives you even more chance, then actually they can be given a clinical letter to support them doing it if they want to do something like that. And obviously lots of local initiatives. So just be mindful of that when you're in those environments. The other big topic that comes up all the time is sleep in adolescent health. And I think many of you talked about that. It's one of the essays that we ask about. And what do we do when we find out sleep's not so good? So I'm biased, but there's a resource from the Evelina, which is on adolescent health, which I'll share with Martina to share with you after this, which takes you through what is physiological about sleep, what do we need it for, what are the kind of age ranges, and how much sleep do you need in each of those, and basically explaining that society is set up for adolescents in a way that doesn't really meet what they need from sleep. But how can you improve things? What does sleep hygiene actually look like in practice? And how do you put those in place every day? And the key messages that have been there for at least the last decade are around your routine. There's a reason that babies and infants, we have such a lot of industry driving how we do sleep for that age group. As parents, people want to make sure that that is preserved. And yet we don't really do, again, the same education around the adolescent years. But that hour before bedtime is the key time. It's the golden hour, if you like, if you want to think about it in that way, where you can make a big dramatic change to how things work for a lot of young people who don't have underlying sleep issues like narcolepsy or obstructive sleep apneas, or things that are keeping them awake and to do with their mental health. But if you have someone who's just got disordered sleep, then you can start to get them to do their sleep routine from the hour before bed. And that includes, no screens. So a paper is better than a screen. Old-fashioned television is better than an iPad. A Kindle or an iPad is better than a phone. And a phone really shouldn't be in the bedroom. And if you're going to do it, you probably have to get the whole family on board, because otherwise it feels a bit punitive. But having phones in the hall, on charging pods or something like that, if you happen to have the ability to. A lot of the young people that I see don't have their own personal space anymore, because we see a lot more in the way of families of refugees or young people who are living in shared housing. So they don't have the facility to put the phone away, but having even a place in the room where the phone goes, that is not in the same kind of eye line as you, is better than nothing at all. So there are ways of adapting it for the ideal and ways of adapting it for the good enough. But it is one of the biggest things that we can do, is to support that aspect of regeneration and sleep in adolescent health, and it will help with a lot of things. And just anchoring a routine is really important. We've talked a bit about mental health support. I think we need to be aware just how busy our colleagues are in CAMHS. There's a lot of excellent community-based initiatives, projects, and Young Minds is a very useful website for sort of explaining things without jargon and helping parents as well, because they have a parental helpline for anyone who's a parent of someone up to the age of 25 with mental health issues. The parents can call confidentially to get advice. So it's a really useful thing if there's a bit of a discrepancy between what the young person is presenting and what the parent is reporting. So be aware of it, be mindful to ask, and particularly the role of the pediatrician, or the role of you in training, is to try and risk stratify within your ability and expertise. So you're not a equivalent of a CAMHS expert. So if you need that, you need to escalate. And we do have liaison psychiatry and people that will be able to come and see young people in ED, and that may take time, but that is there. But I guess in other interactions that you're having, you do need to start to get familiar with what is the risk for this young person and how do I stratify that risk. And there are different ways of doing that that we can talk about in another talk on another day. One of the big areas for young people that I get asked about a lot is transition, and I think this does come up quite a lot in your curriculum. So transition, we're using a term now of moving to adult services, because transition is also associated with other aspects of adolescent health. But basically, we have two groups of young people who are transitioning into adult services. So one are those that have got a chronic health condition which is managed by a subspecialty equivalent. So they maybe have epilepsy, which gets managed by a neurologist once they transition. But then we have a whole other group of young people who've got multi-system involvement, who end up with their transition into adulthood being with multiple teams. So if you think of a young person who's gone from community pediatrics with cerebral palsy, having an annual review for their PT, their orthopedic support, their occupational therapy, their respiratory health, everything coming under one umbrella, and suddenly that comes under the GP with subspecialty support. And in many cases in the UK, we don't actually have an adult equivalent of the service that they use for Botox injection, for example, in young people who have it for tendon release. So we have a slightly odd system where we've not caught up with ourselves with that. We have some where it's really well established. So this case study is a 15-year-old boy who's had diabetes since he was 8. He's got short stature and delayed puberty associated with his condition. He's slowly been increasing his own autonomy over his condition, so takes his insulin, manages his diabetes himself, and is starting to experiment in some of the adolescent behaviours that we can see, where people start to make their own choices about what they want to do, including some cannabis use. But that his control is worsened, and we see that in the years before and then subsequent to moving to adult services. So the things that you probably just need to be aware of as a top line for moving to adult services is the different models of transition, and most places in the UK adopt the Ready Steady Go, which is a transition to adult services using a traffic light system, where you start to have conversations around someone's health and condition, bringing them up to speed with how to do things like making outpatient appointments and how to do all of that, having letters addressed directly to them, and them engaging and coming to clinic and being seen jointly by paediatric and adult services together, and then eventually moving in. And now there's Hello. So there's Ready, Steady, Go, and then Hello for being in the adult service. But it's a stage and not an age. So we often say that from sort of year 9, we'll start to do transition planning or moving to adult services planning, but it needs to be developmentally appropriate. And that's a sort of more recent concept, although not particularly new, but a more recent concept is about a developmentally appropriate healthcare service rather than a transition service. And there are different styles of transition and different things that have got evidence for them, and evidence that makes no difference or is associated with better outcomes. But I suppose what I'd like you to understand is that most cases, if it's a chronic health condition, you're looking at a 7-year process to getting that young person through all the steps that they need to then engage and be autonomous within an adult health service. So it's not a small undertaking and needs to be thought about at each appointment. I'm going to probably leave you here with a few minutes for questions. There's a lot more that we could cover in this, but I think this is a really important voice of young person quote that we have from the Royal College. Waking up after surgery on an adult ward for the first time was nothing short of scary. My parents couldn't stay with me. It felt worlds away from the safe haven of a children's ward, an already stressful time. Additionally, moving to and navigating adult services felt all too much for many young patients, and often transition happens suddenly with little warning. The paediatrician who knew you so well is replaced by a GP who struggled in the short appointments to grasp the whole complex picture. It's a really thoughtful and inclusive explanation of what it feels like. So I think just try and be, mindful of that young person and what they've experienced going through adult services. I'm going to stop talking for
Emma, you've just muted somehow.
Hello.
Hello. Yes.
I was
sorry.
just saying, sorry, if there are things that people want to talk about. I've got a case study on sort of sexual health and, philic competence and things like that, if people wanted to do that in a couple of minutes. But if there are other things coming on the chat, I'm happy to talk about those instead.
I think it would be, if there's any questions that anyone has, that would be fabulous, because I know that some people may be in their working day and they might be in their lunchtime, so they'll only have a little while with us. But that was really very, very useful. Just one from like the signposting of all the resources available, things like Young Minds, which I had absolutely no idea about. But then also that the sort of different communication styles available. Like, I haven't heard of Me First before, so I'm going to be looking that up later, definitely.
Yeah.
And also just bringing it back, I think, to that kind of like professional curiosity that we should all have, and how those media portrayals and those stereotypes really can impact our unconscious bias when we're faced with an adolescent patient presenting with an asthma exacerbation or anything.
Yeah. I think it's a really good way to just think about it as the professional curiosity idea that, you're asking for a reason because you might be able to support or help or find out something that's going to really impact how that young person's experience of healthcare changes. And you never know what someone's going to say. So being aware of where you can signpost people to is an important part of what we do. But adolescent health is like asking someone to talk about general pediatrics in an hour. There's so many facets to it that you could talk about. It can be very scientific, and you can be very, focused on puberty, or you can become very mental health focused and think about it that way. So we can do adolescent health part 2 and think about sexual health and more endocrine and stuff like that another time if you like.
So I think we do have some comments in the
Yeah.
group chat. Just one querying about if we're doing more social prescribing within pediatrics and adolescent medicine.
Yeah. Yeah, so that's definitely something that, particularly within London, so Steph Lamb, who runs the Well Centre, has been doing more kind of social prescribing from that clinic, which is a really good model to see. We've been talking a lot more with GPs. They're more familiar with the social prescribing around sort of activity and gym memberships and stuff like that for young people to be active. But I would say what it probably at the moment for pediatrics, it's not as common as in the adult services to be used and to be thought of. And that's probably because you need more buy-in from the whole family. So there's a lot more things that are family-focused interventions. So particularly around diet and lifestyle stuff, there's a lot more programs that are based on family intervention. So it depends on your criteria. But yeah, I think watch this space. I think it's going to become a bigger part of what we do for sure.
And one of the other sort of comments is absolutely that this has been really very useful, but also the kind of gynecological and sexual health issues around adolescents would definitely be something that would be good to talk about.
So I think very briefly, I think we do know that there's a lot of discussion at the moment about the gender dysphoria services or gender identity services, which is trans health topics. So the CAS review is from Hilary Cass, who's one of the previous presidents of the Royal College of Child Health, is coming through. So that's something to look out for. And we know that referrals in that area have gone from 50 per year 10 years ago to like 2,500 per year. So it's a growing thing. And as generalists in general pediatrics, I think we're going to have to be upskilling ourselves in how to manage these areas. And just one thing, I suppose, on the heads assessment, when you're asking about gender identity, this was something that a young person presented at the conference I was at really recently, and I hadn't thought about it as carefully as perhaps they made me think about it afterwards, is that gender identity and gender expression are slightly different things, which people in this audience may or may not be aware of, but is worth educating ourselves around. But also when we're asking about gender identity and how people feel about their gender identity, it's the sort of, again, it's a more privileged discussion, and it's about asking permission. So saying, would you mind sharing with me your gender identity? And for those that been wrestling with that, the feedback is that that's a kinder and a more inclusive way of asking that question. So that's just a hint and tip that I got in the last year that I've started using in practice. Yeah. So CAS review and think about how we ask that question.
Absolutely. Any other questions or comments from the audience? Feel free to either unmute yourself and ask directly or just write in the chat. I'm not sure we have any other.
That's perfect. That's fine.
Oh, wait, we just have a hand raised. Sarah?
Go for it, Sam.
Yes. Hi, hello. Thank you very much, Emma, for this nice talk. Sorry, my chat is not working in the Teams. So, yeah, you signpost us for great resources. And I just wanted to ask if you can share the QR code of the app that we can do the proper head assessments, if you please.
Yes, of course. I'm going to pop some stuff into the chat, and I'll send some things to Martina so that if chats are not working, you can get a link to those.